Assalamu alaikum. I am Dr. Abdurrahman Muhammad Al. Welcome to today's Cataract Surgery Insight video. Today the surgery is being done by a novice surgeon who has inadvertently touched the iris, which caused the iris to constrict. To correct this error, intracameral adrenaline was injected, but it failed to cause mydriasis. As the surgery continues, the pupil keeps on constricting. Visco was injected prior to creation of the main port incision. The main port was created with a 2.4 keratome. Incision was made while nicking the perilimbal blood vessel. Now OVD is used to cause viscomydriasis, but only mild mydriasis occurred. Since the pupil did not dilate adequately, decision was made to continue surgery by mechanically dilate the pupil with 4 iris hooks. Now, 4 incisions are made for placement of iris hook, and the incision is made with 15-degree knife. One by one, the 4 iris hooks are being inserted into the eye. The iris hook is being inserted with a curved tying and a straight tying forceps. Iris hook will cause significant dilation of the pupil. Now I took over the surgery. Here I am creating a continuous curvilinear capsular axis of 5.5 mm with a bent cysteron. In hard cataract, always try to make a large axis, as it will help in various stages of nuclear management. Let's go express the flap, as this flap might disturb during hydrodissection. Now I am performing hydrodissection in multiple quadrants. During hydrodissection, express out some gel from the AC, then pass fluid or BSS under the rhexis margin. While injecting, ensure that there is small amount of fluid being injected in a smooth, steady flow. Then tap the center of the nucleus so that the injected BSS comes out of the PC bag. This step will prevent capsular distension and posterior capsule from blowing out, which can be seen by pupillary snap sign. Now with the Sinski, rotate the nucleus. The nucleus is rotating beautifully because of a good hydrodissection. Now I will be starting with phacoemulsification. Since it is a hard cataract, I have exposed the phaco tip to a large amount. I did a bit of pre-phaco. Now in scalp setting, I'll be scalping a central crater. Initially I was doing it in pulse mode, then I changed to continuous mode and completed a central crater. Now I'll be performing chop in chop setting. This nucleus is elastic and leathery. See, there is a fiber attached. I'm using the Sinski to cut that fiber. See, again I'm chopping. There is a fiber attached to that piece. I cut it with that Sinski. Now remove this piece and emulsify it in the pupillary plane. Remove the last nuclear piece in epinucleus mode and change the second instrument to spatula. This spatula will be placed in between the nucleus and the posterior capsule, thereby acting as a guard to prevent PCT from occurring. After the removal of the last piece, before coming out, perform viscofluid exchange. Now the remaining part is cortex. Remove the cortex with bimanual. There is significant fibrosis of the posterior capsule, which is not coming out during cortical removal. Even with polish, it did not come out. There was some nuclear piece which was visco-expressed. Again, perform viscofluid exchange. The iris is trying to come out through the main port. There is another nuclear piece, visco-expressed out. The iris is being pushed back with OVD. Now increase the wound size so that the nozzle of the cartridge easily fits through the main wound. Now the IOL is being inserted into the posterior cap. With the help of the spatula, dial the IOL into the posterior capsular bag. With the dialer, check if the IOL is positioned properly. See for 360 degree overlap of the rhexis margin over the optic of the IOL. Now take out the rhexis hook. Rhexis hook is taken out in eye filled with visco. Now I am hydrating the incision made for the iris hooks. With that, I am also hydrating the main port. But during stromal hydration of the main port, the iris prolapsed through the main port. With visco, I repositioned the iris again into the eye. Now, since the iris has prolapsed through the main port, I decided that the wound should be closed with a single suture with a 10-0 molar monofilament. Now remove the visco in visco setting. Remove the visco in front and behind the IOL. Now the case is completed. Hydrate the side ports with BSS. Hydrate the main port. Intracameral antibiotic and subcutaneous dexamethasone is given. Then I also decide to give Pilo intracamerally to constrict the pupil so that there is no further collapse of the iris through the main port or the side port. Thank you everyone. Hope this cataract surgery insight video was helpful in developing your surgical skills.